Okay. Right. Okay. So firstly, I'll just make some introductions. Firstly, we've got Dr. Vickie McDonald, and Vickie is also the director of the Adult ITP Registry, and she's also the lead at the Royal London for ITP. Is that correct, Vickie? Yeah, got it all right?
Yeah, it is. Yes, very
Excellent.
good. Yes, I am. Nice to meet you all tonight.
Good stuff. We've also got Emily Stewart. Emily is a haematology nurse specialist at the Hexham General Hospital. Emily, is that correct?
Yeah, Hexham, and that's part of the Northumbria Healthcare Trust, which is right across the northeast. Great
stuff. And as many of you will know, we've also got Mrs. Rhonda Anderson. Rhonda is a senior patient mentor at the association, and she's always available at the end of a phone if any of you have any questions. And we've also got Anthony Hurd. Anthony is a board member at the association, but he also does a lot to assist me with all the dissemination of information that we have to send out via our various social media channels. Now, I have got a couple of questions here, but does anyone want to start off with a question? No? Right, someone else just joining us.
Yes, Tina does. Tina does.
Tina, far away.
It's a bit off the wall. I was talking to somebody the other day who has asthma and is allergic to all sorts of weird things, including aspirin. And as a consequence of that, she has to be very careful about what fruits and vegetables she eats in order to avoid the salicylates, you know, the sort of aspirin-y type things. I wondered, should we, as we shouldn't take aspirin and ibuprofen, should we also avoid those fruits that are high in salicylates?
Good question. Which one, Emily or Vickie? Vickie, you go ahead. Go on.
I can take that one. So yeah, there's a particular association with asthmatics actually, and a couple of other things that mean that it can, the aspirin or the kind of salicylates can cause quite severe bronchospasm, which is slightly different from what we're asking you to avoid doing with aspirin, which is inhibiting some of the pathways in platelet activation. So the short answer is no, you don't need to avoid the food because the concentration isn't sufficient. In asthma, it is sufficient to trigger that bronchospasm, but in ITP, it's not sufficient to inhibit platelet function.
Wonderful, thank you very much.
Emily, have you got anything to add on that, or no? You're okay. Okay. Any other questions? Anyone?
Bonnie has got her hand up.
Who's got a hand up?
Bonnie.
Oh, hi.
Bonnie.
Evening,
Bonnie, yeah.
everybody.
Far away, Bonnie.
It's an interesting question. I've been iron deficient for since I've been diagnosed for ITP. They also realised I was iron deficient, and my ferritin is at 4. We didn't really do anything about it. Well, I wanted to, but they didn't really want to do anything. Then I started iron supplements, which interacted with the L-Tromapag as we would have expected. So we came off that. But recently, my GP was like, you should get an iron infusion. So I asked my consultant, and they were a bit anxious about doing it. And I was a bit like, please, can we just try? Because the biggest thing around ITP with me is fatigue. I don't mind having low platelets, but I can't bear the fatigue. And I thought maybe having an iron infusion might support my fatigue, etc., etc. I had it done 3.5 weeks ago. My platelet count is generally around 30,000, and then when I'm not very well or when it goes down, I'm about 9,000. I'm on 75 milligrams of L-Tromapag daily, and I hover around 30. I went to the consultant last week, 3.5 weeks after my iron infusion, and I'm at 103,000, and I've never been 103,000. Now, I'm struggling to not connect that with the iron infusion because I've done nothing different, and the only difference has been this iron infusion. But there's not much talk about it. It's a bit like, that's great, isn't it? And I'm like, yeah, could that be the iron infusion? Don't think so. It's just one of those things, your immune system isn't flaring up this time. What do you think about iron infusions or iron deficiency in relation to ITP? No correlation at all, or could have an impact?
Okay, Emily, do you want to go on this one?
Oh, I think it's really a question for Vickie, but from a nursing point of view, I think what you said in your question there about not being able to bear the fatigue, That's something that I hear a lot about in ITP. A lot of people have to endure significant fatigue, but obviously anemia is a contributing factor. So if I was to explore your fatigue problems and try and help you manage that, then looking at your anemia and considering the impact that's having on your fatigue would be really important to me. But I'm going to leave the actual iron platelet side to Vickie.
Okay. Vickie, because fatigue is the number one issue, isn't it, with patients?
Yeah, it is actually. And Bonnie, I think you were right actually to push and explore the iron replacement. So you've covered quite a bit there, and there's probably 2 or 3 bits to pick out from what you were telling us within that story. So first of all, your Eltrombopag, and Eltrombopag at the higher doses, which 75 milligrams is, can do something called chelate iron. So it can kind of promote a degree of iron deficiency, which can feed in. It doesn't usually do it at 50 milligrams. It's more the higher doses a little bit. So it doesn't overly surprise me that your iron levels were low. And I do think it was very much the right thing to do to push forward with getting some kind of iron replacement. And every site is slightly different, but we use a lot of intravenous iron if oral iron isn't tolerated, because often oral iron isn't tolerated. That can make you feel pretty rubbish. Even if you try the ferrous fumarate rather than ferrous sulfate, it's quite irritating to the GI tract. And actually the last thing you want is, when you're trying to manage your dietary restrictions around Eltrombopag and all the other things, is to have something that sets off your stomach. So we do use iron infusions, and they're pretty quick then at improving your symptoms. So I'm pleased that you did that, and I think that is the kind of right way to go. To be fair, some haematologists are a little bit anxious because sometimes with some formulations of iron you can have allergic reactions. So that's why people are a little bit hesitant sometimes. But the more modern formulations are much, much better than they were when I first started training. The final thing about whether iron improves your platelet count. So generally speaking, actually, it's the B12 and folate we generally look at a little bit more around cell production in the bone marrow. But I'm hesitant to say it had no effect, because that's quite a dramatic improvement. And I do wonder whether, because of the higher dose of Eltrombopag, etc., the iron chelation, by just upping your body stores of iron, to a degree, you've given yourself a little bit of building blocks, and you feel a bit better, and your platelet counts come up, and then you generally feel a bit better again. So the science behind it, there isn't anything specific, unlike with B12 and folate, where you'd be very clear about the building blocks for platelet production. I'm hesitant to say it's unrelated, because it just seems a bit odd. And what I would do is track. So keep an eye on the iron levels over a period of time, because you will maintain on that higher dose of Eltrombopag. When they drop again and you start to feel tired again, keep an eye on that platelet count as well. Measure it in parallel and see whether for you that is a cycle, because we do move a little bit as well in ITP to individualization of care. And some of these settings, like some people find turmeric helps and some don't, etc. There are some subtle differences in the way people's ITP behaves. And I'm a big advocate for therefore tracking what happens and helping you follow a pattern, because it then allays some of the anxiety about where some of those symptoms are coming from. Does that answer?
That's great, Vickie. They gave me 1 gram of iron.
Yep.
And when I was at the infusion centre, they said that most people have another dose a week later. But they didn't give me that. They said, we'll see what your iron levels are like. So what would you, he said, my consultant said that I'd only then get 500, like half of that again, because the maximum dose would be 1500, he said. Do you think I should basically have another, what level of ferritin should I try to aim for? Because I don't know what my ferritin is at the moment.
So yeah, so generally speaking, we're kind of, in order to be kind of replete and therefore feel okay, we're generally looking at a level of probably about 50. But once it's drifting below 20 and certainly below 10, that's in our mind where we're moving towards replacing. So, I mean, you've had a good dose, Bonnie. I wouldn't get too worried about additional ones. I would just repeat your ferritin again in a month or so. I mean, you know, you've tolerated it. You can always bob in for a top-up if you need it. And if you feel well, rather than, you know, multiple visits up front, I'd just get your blood count done through a remote system and see what it is. But I would anticipate you'll be fine for a while.
That's great. And just finally, they're absolutely determined that I'm not anemic, and I don't understand how that works. They say because my hemoglobin is fine, I can't be anemic, but with a ferritin level of 4, that's confusing to me.
Yeah, so there's a difference between anemia and iron deficiency. So iron deficiency is the level of iron in your body in the stores, and that's measured either by ferritin or specifically by iron stores in certain circumstances. The anemia relates to your hemoglobin and your red cell, so your oxygen carrying capacity, hemoglobin and red cells. So you can be iron deficient without being anemic.
Okay,
and
brilliant.
That can cause fatigue. So you can be tired from iron deficiency before you hit anemia territory.
Yeah.
And I would very much discourage you becoming anemic and letting the iron deficiency track on for too long.
And that's what I was trying to say. I don't want to become anemic. Let's catch it now. So
yeah.
I'm brilliant. That's so helpful. Thank you very much for your time.
Right.
It's
no
been
problem.
Brilliant.
Okay, any other questions, anyone? And, Anthony, I know you had a question, didn't you? Oh, sorry, Adrian, you got a question?
Yeah. So I'm on 25 milligrams of Eltrompag and 200 milligrams of azathioprine. Diagnosed with ITP back in January with a level of 6, and I was 6. So I'm now back up to around 70. I did peak at 90 at one point. But my main issue is fatigue, as I emailed Mervyn a few weeks ago. And is there sort of any way of managing it, or should I be looking at other treatments such as B12 or iron, as you say, and be suggesting that to my consultant?
Emily, do you want me to answer that one? Yeah, so I think, the answer is yes. Do you mind me asking, is your ITP, so it was a new diagnosis at the beginning of this year?
Yeah, that's right. Yeah, so I had sort of bruising, very extensive bruising across my legs and a bit on my chest. So I'm based in Nottingham, and within 36 hours I'll be diagnosed, most likely with ITP. I was on dextromethasone for a while, and then came off and crashed and back on again, and it was all fairly hideous, really. And
is the ITP out of the blue, or was it triggered by something else? Do they know? I don't know. I mean, I probably had some bruising earlier on. Looking back, I probably had some bruising on my legs, which was undetermined, but it got noticeably worse in January. No particular reason that I can think of. Probably just a reaction to being bored in lockdown or something. I don't know. Yeah. You're right. So yes, looking for other causes of fatigue that we can do something very specifically about, like low folate levels, like iron levels, are really important. Looking for other things that might be associated with ITP that can make you feel tired, like arthritis and other inflammatory conditions. And I'm hoping the haematologist will have looked at that. Most of us do, to try and work out whether we think this is ITP on its own or ITP with something else, because managing all of those types of things is quite important. I'm interested to hear that you're both on Eltrompag and azathioprine, having a relatively recent diagnosis of ITP, and that dose of Eltrompag is relatively low. The average dose normally is 50 milligrams.
Right.
Your platelet count's not bad, and yeah. I mean, there's, generally speaking, people are more fatigued when their platelet count drops, and often that's what our patients will say to us: is I knew my count had dropped because I felt shattered, and I was asleep on the sofa at 6 o'clock at the end of the day. But you're fairly early in the course of things, so it's going to take a little while for things to settle down.
So what sort of time is?
Well, so this is still for you, this is all still very new, and so there's also that comes into play, that suddenly you've got something new to think about. We all take our health for granted very much, and suddenly you don't quite take it for granted in the same way. You've got to think about appointments and the logistics, and it's still not easy to get to hospitals. And one of the drivers, I think, for fatigue, and we've done a bit of a study on this, 2 quality of life studies, both of which the support groups helped us with, the Irish study and the Trapeze study, there's a lot of, some of the driver, I think, for fatigue is anxiety around, underlying anxiety around platelet count, stability, where am I going to go with this, what's going to happen with the treatment, will I carry on responding? And I think that is more challenging to come to terms with. And actually, there's a little bit of that does settle down as your team can give you some reassurance that things are okay, this is what to look for, give you some control back over your life rather than being fixed to appointments. That kind of thing can settle down. The other thing sometimes is if the fatigue and anxiety are a real problem is psychology, but I will confess that even at somewhere like the Royal London, where we have lots and lots and lots of patients, psychology is a challenge. And actually that's where the support association come in, as having people and expert patients like Rhonda, Mervyn, just to touch base with and just give you some reassurance. Yeah. And I would encourage you to talk it through with your team. Sometimes that relationship I do appreciate isn't always recognised by the haematologist, although we do encourage it. And I mean, generally speaking, if at all manageable on a single, I don't want to ever interfere with someone else's management, but just thinking about whether a single agent would do over double, and it may well be your haematologist will come to that. We often go in with something if things are a bit tricky, go in with a couple of things and then start to pull back, and you may well feel a bit better as well when you come back on your medicines a little bit. But it's still quite early days. I know it probably doesn't feel early days, and it probably feels like it's been going on forever. But in the scheme of things,
so what sort of time period would
So we look for stability usually for at least 12 months before we really significantly start to taper and tweak lots of these types of medicines. So you're a little way off that yet, particularly if the diagnosis was the beginning of the year and you've had some steroids and things. So your early stages, I think all the right things seem to have happened, just so that you know the questions to ask about, is this okay? Are there any other reasons for the fatigue? And then giving it, to about 12 months and then starting to say, if everything's very stable, could we start to cut back at things? Because there are a number of patients who ultimately come off their treatments with a steady, stable platelet count. Just because you're on something now doesn't mean to say it'll be for life. It might be for a chunk of patients you do stay on, but there's a chunk that do come off. About a third with the TPO-RAs, which is ultramopagoronopostine. So there's a bit of time to see yet.
I mean, I've had to sort of adjust my work lifestyle. I used to I work for a PLC in so it's pretty intense and a corporate role, and so I'm used to chugging out pretty significant hours like you doctors, and I've had to sort of go on to 9-day fortnights just because I get too knackered and have to Zoom doesn't help because it's very tiring compared to being compared to having face-to-face meetings.
And you do need some bandwidth. The other thing is steroids really knock you off your perch. And it takes some time sometimes for that to settle down. So I don't know when your last course of dexamethasone was, but they can really, we are veering away from repeated doses of steroids. If you read about ITP, many years ago, that was our mainstay actually, and people were often on low dose of steroids for a very long time, and they really do make you feel pretty terrible.
I think I was on 60 milligrams for a while, and that really wiped me out. And so how long would that take to work out my system?
Well, so the effect of it, I mean, we always say, don't. I think it can take 2 to 3 months after stopping steroids before you feel like you're sometimes coming back to the land of the living. Depends a little bit on how long you've been on them, and the longer you've been on them, the longer it can take to come out the other side. So all of these things are likely to feed into that feeling quite shattered, and like I said, needing to nod off on the sofa at 8 o'clock in the evening in front of the telly.
I was probably last on dexamethasone, I don't know, April time, I think, wasn't it?
It's been about 6 months.
So hopefully it's kind of out of the system by now. So I know it feels hard because you will all, if you're working, when we all put pressure on ourselves to be back up to speed and super productive, and it just sometimes you've got to give yourself a bit of a break and say this is going to take a bit of time, and say that's okay to take time and take the time you need to get better, because it will pay dividends down the line.
Vickie, that's incredibly helpful. Thank you very much indeed.
Thank you.
I don't know whether Mervyn or Rhonda or Emily want to come in on that side.
I know
you guys are so good with the psychology.
I know Rhonda's got a question. Emily, do you want to?
I'll I'll add a little bit there. I think Vickie covered it very, fully there, but just thinking about what you've been through, and yes, hopefully, you can, start getting to grips with the physical side of things. The steroids have stopped a while ago now, but also do take a lot of time to process what's happened to you. And I think when you think about your fatigue, I'd really try and unpick it with people. So really the causes of your fatigue, is it just the ITP? Has it been the treatments? Is has the steroids knocked off your sleep pattern? Are you eating okay? All those things, they're all contributing factors to fatigue. And then once you've sort of got a handle on, right, what's causing it, then think, right, what's the effects it's having on me? You mentioned about your work, but, is it stopping you being able to think, concentrate? Are you able to do the things that you normally want to do? Are you feeling, fatigued all the time and just got no energy all the time? I encourage quite a few people actually to keep a fatigue diary, which I know can be the last thing you want to do when you're actually feeling tired, but they can be really helpful because they can get us a real handle on when our energy levels are higher and when they dip, and therefore enable us to manage our day. So focus on, doing the activities that we want to do or need to do if we're working when our energy levels are the highest. So I'd really, if you can, find the energy to do it, spend a bit of time thinking about the causes, the effects, and then the ways to manage it. ITP is, unfortunately, a little bit of a poor cousin compared to some other hematology and other health problems. There's, it is a rare disease. There's not a huge amount of support out there. The support group is fantastic, and I love it. But I would encourage people to look at other sources of fatigue management. So although this isn't a cancer thing, Macmillan actually have quite a lot of good advice about how to manage quite significant fatigue. So, do have a look around on the internet at other websites that, like Macmillan, that can offer quite good advice. They've got quite a good fatigue diary if you want one as well.
Okay, thank you, Emily. Before we go to Rhonda, what I will do towards the end of this meeting, I will put a link in the chat, because tomorrow we've got being launched a new document called entitled Managing ITP. It's a shared decision-making document. We're all quite proud of it. Rhonda was involved in the working group that did it, as was Vickie. And although officially I shouldn't be sharing it until after midnight tonight, I think it's best if I give you all a sneak preview. So I will put a link in the chat and you can go and have a look at it. It's about 20 pages, but it's got some great information there about what questions to ask your haematologist, what the pathway should be, what treatments are available. So hopefully that will help you all. Rhonda, you had your hand up for ages.
Yeah. Well, Adrian, I'm sorry to hear all the problems that you're having, but I think to a great extent they're typical. Now, from a patient's point of view, I think with tiredness and fatigue and things like that, I think the advice that you've been given already is really great, is to look at your day and look at your life and look at your lifestyle. Now, I think you're at a great disadvantage, unfortunately, because you're a full-time worker. So you can't just say, right, I'm going to go and have a sleep this afternoon. But it might be that you do need a bit of extra rest and sleep. And it is very well worthwhile keeping a sleep diary, and also even finding a slot in your day where you can have 10 or 15 minutes of just relaxation and not doing or thinking about anything, sort of eyes closed, nice music, something like that. And that is quite restorative for some people. Now, as Vickie was saying, people are very individual. And so, none of that might work for you, unfortunately. But I think it is really important to do that. The other thing that, from a patient's point of view, I would urge you to do is to give your doctor a hard time. And that is not in a nasty way, but to say to your doctor exactly why am I having this treatment and what is it doing to me? And is it possible at all for my case, which they will know, and I'm not advising you as a doctor or a medical professional here because I'm not one. My advice is to question your doctor very thoroughly and very closely as to all of what you are having, and to see if there is any window there that you may be able to change some of your treatment, because maybe, and I don't know, but maybe that is contributing. I mean, when I was on 120 milligrams of steroids, I didn't sleep at all. I was lucky if I slept for 50 minutes in a night, and I was in hospital for 6 weeks, and I used to do the night duty with the nurses because there was no way I could sleep. And I'd go back to my bed and I was, worried about putting my light on and reading and disturbing people and, listening to the radio or whatever with headphones, of course. But I think that, you've got to look at it very much from your point of view in a sort of selfish way. But it's not selfish, because the most important thing that anybody can do is to actually look after themselves. So this is where you've got to really understand. And I think if you came to more understanding of why your treatment is the way it is and why you're feeling the way you are, you would then come to more of, you would be happier to accept whatever it is that's bothering you. And so, you've got to look at it very much from your own point of view and what is going to be the best outcome for me, always asking your medical professionals what they think and how they can help you. So I hope that's helpful.
Thank you, Rhonda.
Thank you, Rhonda. It's very, very helpful. Much appreciated.
Okay.
Good.
Vickie, you got your hand up?
Yeah, I suppose just following with some, like Rhonda's done, Emily, but just some reassurance. While fatigue can be a challenge in ITP, there are many people who ultimately continue to work at the pace they worked before, or make some adjustments to continue with, it just takes a bit of time. And I think that when you're busy, if this comes out of the blue when you're used to a busy, flat out job, you often give yourself a hard time that you should be doing a lot more than you need to do for a period of time while you just kind of adjust. And it's not always forever. And most of our patients find a very good way round. And it doesn't mean that they can't do the things they want to do. They perhaps just do them in a slightly different way. And it does just take a bit of time sometimes. So I would give it a good 12 months and then start to be thinking, right, do I need to cut back on some of these things like Rhonda said, and maybe think about, can I manage on one agent, and maybe that will make me feel a bit better, and isn't so many other things and tablets, because it's that bandwidth of, I've got to think about this, and I've got to think about that, and I've got work and somebody wants this, and I've got to answer that email at 10 o'clock at night because we're all working remotely. So just, it's okay to cut yourself some slack as well while this settles down, and that's perfectly normal. And if you need support with work for that, your team can also help with that, was the only final thing I just wanted to add.
Great stuff. Thank you very much, Vickie.
Thank you.
Got a couple of hands up. Bonnie?
Hi, this is me again. It's just picking up on the work theme that we just had. So I, over the last 5 years prior to COVID, my platelets every 3 months would drop down to 2,000 or 3,000, and I'd have to have an IVIG 2-day infusion, which is a killer for me. I hated it. But that used to happen every 3 months. Since COVID and working from home, so I've now worked from home for 18 months, I haven't had one infusion. So I've hovered around 30, which is not great for fatigue, but amazing in terms of avoiding IVIG infusions. I can't see that that's not a coincidence as well, that I have had no infusions for 18 months. So my feeling is there's an anxiety and stress and work thing that when I go into work, my body goes into a stress response, and actually that kills my platelets as well. And when I'm at home at my own pace, I can start earlier, finish later, like Rhonda said, nap in the day, but get all the work done. Now, COVID is starting to obviously bring people back to work now. We've seemingly finished COVID. I don't know how that works, but we have. And there was going to be a pressure at some point for me to come back to work. My feeling is I feel I've got very strong medical evidence to say actually working from home is much better for my health. What happens in terms of support for that? Because I guess in the same way as education, you have to be able to make reasonable adjustments. And if I can do my job at home and it affects my health in such a significant way if I go in rather than being at home, is there anybody that does this where they kind of say, actually, I'd like to continue working from home or continue working in this manner because of my health has a massively kind of improved outcome as a result? That was a bit waffly, but I hope you got what I meant.
Yeah, and I can see Anthony's put a little comment as well. We've definitely got a group of patients who, when they're really flat out stressed at work, it makes things worse. And as Anthony said, I think it's often probably multifactorial. You know, we know this is an immune disease. If you're stressed and all the cytokines and inflammatory stuff's all over the place, it's no wonder you feel worse and that you've got less control. And there's the argument for infections and exposure to viruses and all those types of things which we know can happen. So I would suggest an open dialogue with work about how you can make a hybrid model of working work. I think most employers I would hope would be sympathetic to that, and certainly there's a proof of concept that remote working works for a lot of things. I mean, not all fields, depending on what you're in. But even in medicine, we're managing some kind of hybrid model now with kind of on-site, off-site, so that, you know, we can cover all bases and do video clinics as well as face-to-face, but without, you know, swamping people with swamping patients with lots of exposures to lots of different staff. So I think an open and honest discussion, and certainly then, you know, asking your haematologist that actually, if you've noticed such a difference, would they be able to help support that?
So I asked my consultant, I plucked up the courage to do that because I'm not really somebody who wants kind of extra special support and things. And I floated it with him, and he said, you're not immune compromised, so there's no reason why you can't go to work. And that wasn't my point.
Emily, what I mean, nursing wise, this is probably something you perhaps, even if you've got a general heme hat on, you probably got quite a few different groups where you support that work transition.
And yes, we do support a lot of people that are, you know, are adjusting back to work after an illness, or coping with an illness and living with an illness and working. And yeah, from my perspective, it is about having that really open, honest conversation with your work. There should be an occupational health department that related to your work. I don't know what your work is, but they should certainly have, you know, they should be all ears to what you're saying, definitely, and listen very carefully. Sometimes as a haematology team, we will offer to have communications with people's work, with their occupational health departments, to explain the sort of impacts that the treatments, the disease itself can have on somebody, if that's needed. For me, I also often say to people, it's about going and not only explaining what the problem is, but the impact that it's having on your life. And, you know, you gave us some very clear detail there about the fact that it has an effect very physically on you. It's, you know, it means that your platelet count is not so good, and if you need more treatment. So I think taking that very, you know, those very specific things and saying, this is the impact of working in the office has on me. And if you can demonstrate that working at home is also, you know, is very effective for the company, then I would imagine that they're going to be very sympathetic towards that, and hopefully offer you some sort of combination working of either working at home or working part-time at home, part-time in the office. But yeah, I definitely chat to your team a bit more. Do you have a nurse, Bonnie, or not?
Did you say, do I have a nurse?
Yeah, do you have is there a nurse?
There is, but they swap around a bit, and I had one for about 4 years and I had quite a good relationship, and then she went on maternity, and there's a new lady, and she doesn't really know me, and we just have text messages, and I'm not really connected anymore because I don't really ever see her, because usually every consultant has a nurse sitting in, but now the consultant I see doesn't have a nurse sitting in, so they don't know me. I'm just a sort of name that kind of pops up every now and then saying, what are my results? But no, I've lost that sort of relationship really.
I mean, if it's possible, it might be worth trying to nurture a relationship with a nurse there again and get that relationship going, because hopefully we can be quite helpful in understanding the impact of your ITP is having, and what your personal circumstances are, and give you a bit more sort of detailed guidance for your personal situation.
I don't know. Even though my consultant was a bit like, well, you're not immune compromised, and that wasn't the point I was making. I was just saying the impact in terms of needing more treatment is what I'm talking about. I hate having IVIGs, and it's expensive for you guys to keep giving them to me.
And it's also resource at the moment.
Not, your work, I don't know if you have your IVIG on a day that you're supposed to be working.
Yeah, I have 2 days off. 2 days off, and then like 3 days afterwards, so, I'm crippled in bed with like massive migraines.
It's kind of not working for anybody now, is it?
But, no.
So, and I did pick up that immediately when you explained the situation, that you'd spoken to your hematologist, and maybe perhaps they just didn't pick up on what you were actually saying there. But that's what I mean, as nurses, we quite often have, we hopefully have sometimes a bit more time just to sit down and talk about the sort of bigger picture, and we maybe so yeah,
that's a really good idea. I'll reconnect with the nurse that I had before. That's a really great idea. Thank you.
And Bonnie, sometimes just a second revisit of the conversation. I mean, sometimes it takes 1 or 2 conversations to just navigate a kind of ground that works really. So, if flagging it again just should flag in the physician's mind that we've not quite resolved this issue for this patient, and maybe we need to just kind of revisit it. So I wouldn't be afraid of opening that dialogue again either, and just saying, are you sure?
Okay, brilliant.
Yeah.
Thank you.
Thank you, Vickie. Thank you. Adrian, you got your hand up?
Yeah. So what do you think causes ITP? I mean, could it have been caused by stress, etc.? I mean, I used to work. So pre-COVID, I was working bonkers hours and driving 20,000 miles a year all over the UK, and working at opposite ends of the day.
I think Anthony's got an answer to that.
Yeah. The problem is with ITP, there are lots of very complicated processes going on in our immune systems that sort of go into the mix. So it's very difficult to pin down any real definites about ITP. That is the one thing that I took from my diagnosis with it 15 years ago. The only definite thing you can say about ITP is that nothing is definite. So many different things are going on, and what might apply to one of us might not necessarily apply to others amongst us. There are some very useful videos on our YouTube channel about what causes ITP and what's actually going on in our immune system. The best one, I mean, I hate to prefer, but John Semple's one is the best one in terms of explaining it in lay person's language. He explains it in a way that most people will easily understand. So I can't recommend that one more, really. John Semple's one is fantastic. It tells the story of what's going on in our immune systems to cause ITP and what the actual responses are. But in terms of what causes it in each of us, it's very, very difficult to spot the actual trigger. We do know that we all have to have the genetic makeup to develop ITP. So every one of us that has developed ITP must first of all have the genetic makeup to do so. Because we've got the genetic makeup, it doesn't mean that we will go on to develop ITP. There has to be a trigger somewhere in our lives that enables us to develop ITP. For some people, it could be a response, dare I say it, to a vaccination. In children, it can be the MMR jab. We know that that is one thing that can be a cause. We do know, of course, that other vaccines, as has been well publicised, the flu vaccine, COVID-19 vaccines can be a trigger. It could be a response to an illness that we've had, where our immune systems just haven't rebooted properly. They've been diverted, if you like. They've been sent on the wrong path. It could be as a response to stress, and I say it could be, but we really don't know we can't prove it. That's the difficulty. So it could be stress, it could be as a result of our immune response to something that has happened in our lives, a life event, like a divorce, separation, bereavement, or an accident. But I again stress, it could be, we really can't prove it. So all of these things have to go into the pot, and it's very difficult to pin down exactly what it is for any one person, albeit with things like vaccinations, then it's a bit more straightforward to pin it to something like that. It could also be a response to other drugs that one has been on for other illnesses. So that's why it's very important to tell your health professionals and your specialists all the drugs that you may or may not have been on in the recent past for other illnesses, because again, they can rule in or out those types of causes. But I hope that's helpful, even though it sounds very complicated, because it is very complicated.
Thanks, Anthony. That's actually a very good segue, especially about the vaccines, to a question I got from a lady.
Oh no, not the vaccines.
From a question I got from a lady. She's got 2 children, one's 12, one's 14. The 14-year-old, not a problem. Happy for them, the 14-year-old, to have the vaccine. But the 12-year-old is had ITP. It was originally diagnosed after the MMR jab when they was 2. They've been in remission now for about 4 years, but she's a bit anxious about should the 12-year-old have the COVID vaccine after the experience the child had with after the MMR vaccine. Could it reignite the ITP? I know it's an open-ended question, and over to you, Vickie.
I thought that was coming my way.
Yeah.
Gosh, I think for children, this is quite a tough call. I think
it is.
I'm going to chicken out and talk about adults first. And generally, on balance, the recommendation is that we have people protected from COVID, particularly if patients are on immunosuppressing medicines, so you don't want to get severe COVID. And I think that risk benefit is in my mind, obviously it's a personal choice and you'd never enforce it on anyone, but the risk benefit is very much in favour of vaccination. There are 1 or 2 patients of ours that have kind of, when they've got really, really, really tricky ITP, but even they ultimately have said, that's fine, we're going ahead, we're doing it, and have been okay. And we've got a mixture, it's starting to come through in the literature, but we've got the vast majority of our patients who've been vaccinated have had absolutely no change at all. We've had a small number who developed ITP after the vaccine. We've had a small number whose platelet counts got better after the vaccine, particularly the mRNA vaccine rather than the AstraZeneca. The children, if I'm honest, I would probably direct that question to the pediatric group, because I think the advice around vaccinating children has been about the wider community benefit rather than an individual risk benefit for avoiding getting severe COVID or long COVID. I mean, I think COVID can happen in children, and I think some children can get severe COVID. But I think my understanding of listening to Chris Whitty and the team is that is a broader thing about avoiding disrupting their education rather than them becoming medically very unwell. And that balance against tipping over into ITP, most childhood ITP resolves very quickly. So in all probability, if it did trigger it, it's very likely that it wouldn't be chronic ITP. It would be a short spell with a low platelet count and everything get better. But I might be inclined to direct that question towards those, because I don't treat children at Mervyn. That might be one to go to the children's group to see what their take is on the risk benefit, because I think that is, the child is probably not going to get sick from ITP, but also the child is probably not going to get sick from COVID. And I think that is a harder balance to make, and probably not one that I would be making on a day-to-day basis anyway. So it's possibly not fair to plump one way or the other.
No problem at all. I will ask Nicola Cooper that on Wednesday.
Yeah, I think Nikki would be well placed, because she does a big children's
it's a lady who would have been here but couldn't make it tonight. This one. Okay, I've got another COVID one. there's been much talk, again, it's another person who couldn't be here tonight, been much talk about vaccinating people this autumn with a flu jab in one arm and the COVID jab in the other on the same day. I'm unclear as to whether this is actually safe for people with ITP. Would it be wiser to have an interval of, say, at least a week between the two jabs? So
that's a good question, actually, a really good question, and I think one we probably don't have the answer to. But I think, yeah, I mean, it is both of those can also make you feel a bit achy and groggy, can't they? So two at the same time could be kind of a double whammy. I can't see there would be any harm in separating those out if you were more comfortable with managing the symptoms around it. As like I said, you can feel a bit rubbish with both. Everyone's going to be getting mRNA, aren't they? So the Pfizer, Moderna rather than AstraZeneca as a booster can make you feel a bit kind of achy. And flu can for sure. The other reason for separating, I suppose, would be if you found that you were running into issues after one or other, you could more clearly work out which one might be the culprit. Now, that obviously separates them out, and that's only Dr. McDonald's personal opinion, but arguably there might be a rationale for separating them and being clear then, which one makes you feel a bit worse and which one might, although the risks are not huge, and it's essentially the same with COVID. In fact, it's probably less with the mRNA COVID than it is with
interesting point, because people of a certain age will be coming up for the flu vaccine, but may also now be able to get the pneumonia vaccine as well. So if they got them two, because my wife had one in each arm last Friday, so if you got that and then you're also due the COVID booster, you're going to run out of arms eventually. So it'll be an interesting point.
Actually, I did ask Adrian about that. Professor Adrian Newland, who is also one of our medical advisors. And I said, what about having all these vaccines? I didn't actually say on the same day, but he said that the body's immune system would sort it out and that you wouldn't actually get overloaded. But I don't know if you had three on the same day. I mean, they give the triple, don't they, Vickie, to the children?
Yeah.
They give a triple vaccine, but of course that has all been worked out previously. So I don't know. I mean, going back to the stress, I would like to say that when I had ITP, I was in a teaching job, only teaching little children, but it was a very stressful school to teach in. And that was when I, got my 0 platelet count. And I always thought to myself, was it the stress? And I came to the conclusion that it wasn't actually the stress, but that stress isn't good for anybody. And that, all of these things are factors. And I put in the chat about mindfulness apps and things like that. And some people do find, I know if you're tremendously busy with work, it's very hard to find the time, but some people do find exercise or yoga or, going to the gym or these mindfulness apps or reading. There's lots of books about such things. And I think that they do actually channel you into ways of dealing with stress and anxiety.
Okay, thank you, Rhonda. Another question that comes up a lot, and again, I'm sorry to say it, but again, it's the COVID bit, but it is linked to people with ITP. For those people who are vulnerable, immune compromised or suppressed, they're having a booster jab this year. Do you think they will end up having a booster jab every year in the future?
A COVID booster jab?
Yeah.
I think it's a real probability, I would imagine. I mean, we're not party to more info in our setting, I think, than there's widely available in community and news. But I would well imagine it'll be something like flu. But obviously it's a bigger group of people. The flu was only offered to certain groups of people. I think COVID would be wider. I think there are animal models of the mRNA vaccine having several viruses, so protecting against respiratory syncytial plus COVID plus flu. Whether ultimately that will be something that's translated into a human model, I don't know. But at a guess, I would say yes, this is going to be certainly for the next few years, something we're going to need to be protected against and updated if the slight variants trickle along.
Interesting one. Thank you, Vickie. Thank you. Any other questions, anyone? No? Have I got any more here? Let's have a quick look.
Tina, I think Mervyn was just popping.
Tina?
I just wondered, it was something that I'd asked Emily about in the clinic, but could Emily just give us a quick run through, especially for Adrian and anybody who's sort of newly diagnosed, when you look at the blood results, we're sort of, what's the platelets? But you're looking at all sorts of other things. Could you just give us a quick run through of what the other things are that are important and what they tell you, please?
I can do, but you know what? This is my first meeting and I'm slightly nervous and I've got a hematologist, so I'm afraid I'm going to pass. But Vickie, essentially I look at the full blood count and just to check everything else is okay in the LFTs and the U's and E's. So, but I'm going to let Vickie answer more fully than I will, if that's okay.
Yeah, so when we get a full blood count, we get lots of different parameters or measurements. So like you say, the platelet count is one of the things we're looking at. We're also looking at the hemoglobin, so to see whether you're developing anemia. More subtly than that, we can also look at the size of the red cells. So we get some measurements that tell us how big your red cells are. And if you're iron deficient, they get small. And if you're B12 and folate deficient, they get big. We're looking at your white cell count. We're looking to make sure that the balance of all of those things is okay. And that is partly to do with, you might be on medicines that suppress the immune system, like azathioprine, mycophenolate, you might have rituximab, so we have to make sure that the white cell count's okay. And partly to make sure there isn't any evidence of anything else that might be driving the ITP that we need to tackle as well as the ITP itself. So broadly speaking, those are the parameters that are relevant and useful for an ITP patient. The other things we might measure depend a little bit on where you are in your ITP journey. So there's a whole load of things we do at the beginning to look for, as I've said, whether this is ITP that's come out of the blue or triggered by virus or vaccine or whatever, or ITP because of another autoimmune disease like rheumatoid arthritis or lupus or other things, which is rarer, but still a thing we have to look for. We also at the beginning look for things that might determine what type of treatment we would use to manage your ITP or kind of tweak a little bit. And then once you're on your journey of whichever medicines you're on, we then have to look for whether any of those medicines might affect other things like your kidneys and your liver. So if you're on altromopag or mycophenolate, you should be having your liver function tested regularly. At the beginning, it may be every 2 or 3 weeks, but by 3 months, it should be 3 monthly. So there's a variety of things we look at depending on whether we're in the diagnosis phase or the monitoring phase and depending which treatment you're on, but also more specifically about also picking up subtle signs for other things that might make you be feeling tired or things that we just need to intervene on. The other things in other centres, some of the bigger centres, we also may do some research. So we may be taking samples for research, the ITP registry being one, but other studies and things aren't trying to understand why people get ITP, how we can decide who responds to which treatment, how we can risk stratify patients and try and work out the appropriate sequencing of therapy. So depending on your centre, you may also be having blood tests and we may be looking at some of those things a little bit. If you don't, it doesn't matter. So don't worry if you're not in one of those centres. And generally, we've got networks available to get people into studies more widely if your centre can't do it or your hospital can't do it. But the basic stuff, as we talked about, would be the types of things they're looking at. Does that answer that, Tina? Have I said anything scary or weird?
That's brilliant. Thank you very much indeed. Lovely. Thank you.
Thank you very much, Vickie. Thank you, Tina. Any other questions, anyone? Is Sarah on here still or is she gone? Because I know Sarah had your hand up earlier. Then you put it down.
I did, because it was answered.
Oh, good stuff. Okay, okay.
And
Bonnie, you got your hand up?
Nice to meet
Yeah,
you
a
all.
really quick one. I always feel really awkward about thinking about going for a second opinion or moving hospitals or speaking to another consultant, because I really value and kind of really appreciate what my consultant's done for me already, and taking me out the depth of despair, because I was at a local hospital to start with and they didn't know what to do with me. They just wanted me to kind of leave, really. And then I went to my consultant and it was like being given the gift of life again. So I feel really loyal to my consultant, therefore very disloyal for me thinking right now I'd quite like to see what someone else would think of what my situation is. And that's always stopped me from maybe venturing out to see what other consultants might say, because I don't want to offend my current consultant. How do you navigate that? And is that just totally ridiculous?
Just checking I wasn't muted. It's not, although I think if this particular consultant has kind of got you out of a tricky patch and some stability, then generally speaking, that relationship's there. The way I would tackle it, Bonnie, is to say, you know, what are the new developments in ITP? You know, what's happening? Because there are some, you know, there are studies and not everybody's necessarily eligible, but across the country there are the opportunities to take part in clinical trials for ITP of novel therapies, if that's what you wanted, although remembering that clinical trials often have a greater commitment to when you have to turn up for your appointments and when you have to turn up for blood tests and standard clinical care, so that as much information is gathered. So they're often quite time and labour intensive. So I would approach it by saying, what's new in is there anything new in ITP? Should I tackle another way? You know, without knowing your history, Bonnie, I guess if you're on regular IVIG and many other lines of therapy haven't worked, the options are of which we've got a big chunk of patients whose platelet count is less than 10, and we just intervene as and when required, and they can manage that. We've got some who can't manage that and who go through sequential studies if they've got tricky ITP. Others are very stable on their therapy. So I think the dialogue with your consultant of just being open and honest and saying, what else is out there? Is there anything else out there? Have things moved on? What do you think? Is probably the first discussion to have, because it may make them go, oh, okay, well, yeah, no, we haven't got anything, or yes, we have, or we haven't, but the hospital down the road has. Would you like to go and see them, or I can drop them a line, which usually is what happens to us at London and our little region. They will email me and say, I've got this patient and they're quite interested in X. What do you have any trials or anything you can offer as a discussion? I mean, I'd be interested in the patient's perspective, because, you know, some of you may have been there and wanted to do that. Perhaps, you know, it's all very, I think it's easy to say because I hope we're approachable, but that's easier said than done sometimes, isn't it? So, you know, perhaps from the patient or nursing perspective, a top tip on accessing the latest or the trial.
Anthony, you got your hand up?
Yeah, I mean, certainly first thing to say is never be embarrassed to get the best treatment you can for yourself. You owe it to yourself, don't you? That's the bottom line. So don't be embarrassed about asking. On the ITP Support Association YouTube channel, I've just typed a note on the chat section. There are two superb videos, one from Dr. Drew Provan, the other from Professor Newland. They look at the current treatments and the current options available for folk at different stages of their ITP journey, really. So that's really well worth checking out, both of those. But also, depending on who your specialist is, bear in mind that across the UK now, we've got specialist centres of ITP expertise that are now set up. I mean, when I was diagnosed back in 2006, those didn't exist. We now have centres of excellence where there are properly designated ITP experts available to look at your case. Now, I personally am not covered by one of those specialist centres, but my specialist does talk to one of those specialist centres about me very regularly, because he was candid enough to tell me all about that. So I am very confident about the person he's talking to, and I won't say who that is, but anyway, it gives me great confidence that that is the case. So you'd be surprised that if you're not being treated by one of the specialist centres, all of which are listed on the ITP Support Association website, if you're not under one of those centres, ask your specialist, do you interact with one of the specialist centres? And if so, which one is it? Because
that's where it's a little bit awkward, because I am in a specialist centre.
Ah, right. Okay. Well,
that's and that makes me feel like I'm judging them, and I don't ever want to feel that.
Yeah, I can fully understand that. But I think, first of all, no harm in the thought of going to get a second opinion. I think there's no harm in that at all, and be absolutely open and honest about it.
Yeah, so before COVID, I had this conversation, and we started talking about trials, and then COVID hit, because I did everything, and then M-Plate totally bombed out on me. So then COVID came, so they put me back on Eltromapag, and I started responding. So I'm hovering around 30-ish with Eltromapag, but a colleague of mine at work bizarrely had ITP after being pregnant, and saw Dr. Provan at Royal London, and she doesn't have ITP anymore. Now, I know we're all really individual, but I'm a bit like, I'm a bit sort of like, I wonder what would happen if I just had a different perspective. That's all.
Very difficult.
It can be a fresh eye approach, but I don't know how to have that conversation without upsetting anybody.
I correspond regularly with a guy in the United States who has failed on everything so far. And that includes all of the TPOs, all of the immune suppressors. So he's now going on to Tavalisse, which is the other name for it is fostematalaternib or something. It sounds pretty much like a Welsh village. I don't know. But nevertheless, the product name is Tavalisse. And that, if you look at Drew Provan's video and Adrian Newland's video, they will explain where these new drugs fit in and where our specialists might be using them. So I would recommend having
also
both of those.
In the new shared decision-making document that I've actually put the link for. That explains all the available treatments and the new treatments in there. So, that should actually give you a lot of questions that you could use to actually ask your
Tavalisse and Dopplertet is not licensed yet to be used, is it?
In Scotland it is now, isn't it? Or
but not down here.
Scotland,
I think I've tried everything that's allowed.
I think it's on the way, isn't it? I think.
It may be on the way. It's gone to appeal, so yeah.
But each case is, thank goodness, we're now treating each case on its merits, and each individual as an individual, which we weren't doing back in 2005 when I started out on this interesting journey, shall we say.
Pat, I believe you've got a question. Pat? Did you have a question? You're muted there.
This might be a bit belated now, but I wanted to tell Bonnie that, she used to have IVIG, and actually right now, because I usually have that, and at the moment, they said there's absolutely none available in the world, or hardly any, because since COVID, people have not been donating blood and plasma. So they've put me on Revelade, and I was wondering if anybody's on that and if they're having side effects, because I've just started and having a few side effects. Is anybody else on it?
Wendy?
No. Oh, Wendy.
You're muted, Wendy. Bottom left. There should be a microphone there with a red line through it, so just click on that.
Shall I answer while Wendy's just finding her unmute button?
Go on, Bonnie, fire away.
So I'm on Eltromapag, the same as Revelade, and I found that I had horrendous headaches and really dodgy stomach for about 6 weeks. After that, everything fine. So I feel like this might just be for me, but once you get over the back of like maybe just over a month of taking it, I think your body sort of acclimatizes and things go back into a normal rhythm. So I don't know sometimes what's ITP and what's the side effect of the drug. So I'm on 75 milligrams, but I really do know, stick with it for at least 6 weeks, I think most of your side effects will drop. And I've been off it, lost response to it, taken a year out, and then gone back on it, and I'm responding vaguely to it more than I do anything else. And I always go through the side effects and then they stop. So I hope that reassures you.
Thank you. Wendy?
How many milligrams did you take? Was
75 at the moment.
I'm not fine.
Wendy,
Sorry.
we can hear you now.
Good. Yes, I'm on 25 milligrams and I've had no problems whatsoever with it. We've tried a few things and then finally I've got my platelets up to 130 now, and they start at 19. So over a couple of years trying the different things, I'm now on this and that. Personally, as you say, we're all individuals anyway. Personally, I've had no problems with it. That helps.
Okay. I was on 50, and so he decided to reduce it every other day, and that is helping. So maybe it's the 50 milligrams that's too high, because you were just taking 25. Yeah. Is that right? Mm.
Yes.
Thank you. That's helpful.
Thanks so much, Wendy.
That's right.
Yeah. Regarding IVIG, we have been involved in a publicity campaign with NHS Blood and Transplant, trying to encourage people to actually donate plasma. So hopefully that will work. Right, last question now, I think. Sarah, you got your hand up?
I was just going to reply to Pat, if I could, please, just to say that I'm on L-Trombopag, 25 milligrams alternate days. I started over a year ago. I've had quite a lot of symptoms stomach-wise with it, but it has settled over time. And I've got a stable count of around 80 now.
Good stuff, excellent.
25 alternate days has been good for me.
Yeah.
Initially, I was on 50 daily, and mine shot up to over 600.
Oh dear.
So that was within a couple of weeks of starting it. So then, obviously, we quickly reduced the dose and obviously settled for 25 alternate days, and it's been pretty good. It gives me that reassurance of a stable count. I'm not obsessing by numbers.
Thank you very much, Sarah. Bonnie, you still got your hand up. Is that from before?
Yeah, sorry, I'll put it down. It's starting to ache, actually. I better put it down.
Yeah, okay, everyone. I think we come to the end. Can I just thank Vickie McDonald and Emily Stewart for answering the questions. It's been excellent. And also everyone else who joined in, Rhonda, Anthony, everyone who joined in, Pat, Tina as well. Thanks for the idea of this group. Excellent start. Like I know we've all had more. Thank you very much.
Right. So, I just wanted to say before you completely finish, Mervyn, that I've given the prize for the best dressed to Sarah tonight because she's wearing the ITP t-shirt. So well done, Sarah.
Great stuff.
Can't see
Great
it.
stuff. Thank you. And if you do have any more things, this is ITP Awareness Week. We've got the shared decision-making document being launched tomorrow. You've all got prior access to that now. We've also got the Pediatric support group meeting on Wednesday evening with Dr. Nicola Cooper. Anyone can actually join in that if you've got any questions. And we are planning to have, just waiting for confirmation, hopefully 7 o'clock Friday evening, we will be having a joint webinar with ourselves in the UK, the PDSA in the States, and ITP Australia. It's a joint thing for about an hour and a half. We're actually pre-recording it because of the time differences. Adrian Newland's involved, but that will be going out hopefully 7 o'clock Friday evening via our website and social media. So you're all welcome to view that. So thank you, everyone. It's been a great meeting.
Thank you very much.
Look forward to seeing you all again. Take care, everyone.
Thank you.
Bye-bye.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Thank you. Thank you.
Bye.
Excellent.